Okay, I think this is a good time to start. Hello, everyone, and welcome to another session of the Virtual Global Spine Conference. Thank you to everyone for joining us. I am absolutely thrilled to welcome today our speaker, who is very well known to all of us, and I think to many people here as well. Dr. Amna Hussein is one of our research fellows at the University of Arizona College of Medicine in Phoenix. She has been with us for almost 2 years now, doing an absolutely great job. And also behind the scenes, she has been critical to the operations of Virtual Spine, actually. So she has multiple roles for sure. But I'm really thrilled today to invite her and host her as a speaker, specifically to talk about her work on a very important topic, which is best practices in the management of spine emergencies during pregnancy. These are very, very critical and really clinically meaningful research and guidelines and best practices, because they're such challenging conditions to treat during a time where one has to make rapid decisions. And they involve typically neurosurgery, spine surgeons, anesthesia, sometimes obstetrics. And so it's a very dynamic and challenging area. And she has done a great job doing quite a bit of research on this. She has presented this at several conferences nationally. And I'm really excited for her to be presenting today, putting all the thoughts together and sharing with us what she has learned on this topic. So Amna, thank you so much for joining us. Thank you for all that you do, of course, for Virtual Spine and beyond. And welcome.
Thank you so much for the kind introduction, Dr. Baj. And I'm really honored to be here and presenting in the Virtual Spine. And good evening, everyone. Thank you for joining, and thank you for the ones who will watch the recording of this session. So today I will be talking about best practices in the management of spine emergencies during pregnancy. Despite the huge advancement in the antenatal care, we still lack clear guidelines for many spinal and neurosurgical pathologies that occur during pregnancy and also during antepartum period. So disclosures, there is no conflict of interest in this presentation. Part of this work was presented in the spine section and CNS 2023 as oral, poster, and digital presentations. So we will start our presentation with a case that presented to Dr. Michael Prem, our assistant professor at Banner, and he had a very interesting consult last year. The case was 27-year-old female present with bilateral lower extremity weakness and urinary retention. And also she had a history of multiple falls and several weeks of numbness and tingling in her lower limbs. Her power in the upper limbs was normal. In the lower limbs examination, hip flexion was 3 out of 5 bilaterally, knee extension was 2 over 5, and distal muscles were 1 over 5. And she had upgoing toes bilaterally. But the patient was 37 weeks pregnant. This is her MRI. And challenging case, right? It's not that common, but it can happen. So the patient underwent urgent cesarean section in the morning. It was followed by laminectomy and tumor resection in the afternoon. She recovered some of the functions immediately post-op and then continued improving in her lower limbs. And her infant was healthy baby boy. So what's the right answer when we encounter such cases? We have many considerations when we are dealing with patients with spinal or neurosurgical pathologies during their antenatal period. First of all, we have the neurological considerations, starting from the diagnosis itself, the accuracy of their exam, what imaging modalities are we going to use depends on their gestational age. We have obstetric considerations, including the fetal health, the obstetric and gynecological status of the patient, and future pregnancies. Also, if the patient will go to surgery, what type of anesthesia she will have and the positioning during surgery, and many other factors that will play a role in the management and in the decision-making to make sure that we will have a favorable outcome for the fetus and for the mother. So spine pathologies during pregnancy are rare, but it happens. And the incidence seemed to increase because of the advancement in maternal ages in the last decades. And also normal physiology of the pregnant woman can play a role and contribute in the management and in the outcome. Some physiological changes, including ligamental laxity, especially in the lower back and in the pelvic, relative osteoporosis, and postural changes. The pathologies that we might encounter during antenatal period, and it's increasing over the last years, including degenerative changes, disc herniation or subluxations, and spontaneous hematomas, and sometimes patients might have other medical illness, including preeclampsia and HELLP syndrome. And also we have tumors. In the literature, it's reported that meningiomas and hemangioblastomas are rapidly increasing and becoming symptomatic during pregnancy. And also we have traumas. Here at Banner, we managed to search about common or like many spinal pathologies that occur during pregnancy, and we looked for the management of these things. And in the literature, we find many case reports, a few retrospective studies. This work is ongoing with us. First of all, we have the degenerative pathologies. We conducted a systematic review, including 33 papers and reporting 53 patients. These patients are having degenerative disc disease, which might progress to coda equina syndrome during pregnancy, and it was symptomatic. The results, in the results, we had 53 patients with average age of 33 years and mean gestational age in the second trimester, 24.4 weeks. And the main symptoms of the patients were pain. Pain was the commonest presentation in 98% of the patients, followed by sensory changes and motor deficit. And nearly half of the patients presented with coda equina syndrome. Most of the patients presented with single-level lumbar disc herniation, which is including L5S1 in 58.5% of the patients, and L45 in 45% of the patients. The management was conservative in 11.3% of patients. Some patients had delivery followed by spine surgery, and some patients, or the majority of patients, had antepartum surgery. 31 patients had microdiscectomy, the others were not reported, and the average gestational age for the patients who had antepartum surgery was 23.3 weeks. So here is a small summary of the patients who had antenatal spine surgery. Their intraoperative positioning was solely dependent on their gestational age. The majority had surgery in prone position. Some had it in lateral position. The majority were left, but there were one reported in the right, and knee and elbow position in one patient. The anesthetic modality chosen were general anesthesia in the majority of patients, but some patients had regional anesthesia. The outcome, antepartum surgery group delivered via vaginal delivery at term or cesarean section. Most of the patients who delivered through cesarean section was mainly due to obstetric reasons, like previous cesarean delivery or premature rupture of membrane. And all neonates were healthy with normal post-neonatal development. 31 patients had complete neurological recovery. 19 patients had partial recovery, and the majority of them were in the coda equina syndrome group. So here is a summary of the decision-making for the case reports that we collected for patients who presented with coda equina syndrome and herniated lumbar disc during pregnancy. The patients who presented with herniated lumbar disc required MRI and then conservative management. If failed, it depends on the gestational age, because according to the American Society of Obstetric and Gynecology, it's safe to perform non-obstetric surgery after delivering the baby when the mom is more than 34 weeks. So when the gestational age is more than 34 weeks, we can perform delivery followed by spine surgery on the same setting. If the gestational age is less than 34 weeks, then antepartum spine surgery, followed by delivery at term, whether vaginal or cesarean delivery. If the patient presented with symptoms of coda equina syndrome, including urine retention, then MRI for diagnosis, and depends on the management depends on the gestational age. If the gestational age is less than 34 weeks, then the mother will go for antepartum spine surgery followed by delivery at term. If it's more than 34 weeks, then delivery followed by spine surgery. The second pathology that we searched was spontaneous spine epidural hematoma, which happens, but interestingly, because the pregnancy is a hypercoagulable state, we don't expect a pregnant woman to develop spontaneous spine epidural hematoma. In the literature, we find 23 publications, including 25 patients only. The average age was 28.6 years, and the mean gestational age was 32.9 weeks. 19 patients presented with no previous past medical history, while one patient had antiphospholipid syndrome and she was on anticoagulant. One patient presented with HELLP syndrome. One patient had twin pregnancy and 16 weeks gestation, and 2 patients presented with preeclampsia. Their primary complaint was pain. That pain was between the shoulders, between the scapulas, or shoulder pain. And it was associated with neurological dysfunction. 14 patients presented with complete paraplegia, and 8 patients presented with incomplete paraplegia. Here we can see that the majority of spontaneous spinal epidural hematomas presented in the thoracic spine, 65% of it, followed by cervicothoracic, and then cervical spine and thoracolumbar were the least presentations. And the majority of patients had hematomas involving 4 to 5 levels of their spinal canal. The management of patients presented with spontaneous spinal epidural hematomas was cesarean section, followed immediately by spinal decompression in 14 patients, as these patients presented there late in their pregnancy. They were in their 3rd trimester. Antenatal spinal decompression was done in 9 patients with a mean gestational age of 25.8 weeks. And 2 patients had conservative management. These 2 patients presented only with pain, and there was no neurological deficit indicating decompression during their presentation. And their outcome was excellent. Simple hematoma was the finding in 24 patients. Only 1 patient had AVM that led to spinal hematoma. Complete recovery was observed in 11 patients. Significant improvement was reported in 3 patients, and incomplete recovery with unfavorable outcome was reported in another 11 patients. As we can see here, the numbers were statistically not significant, maybe because of the small number of patients. We had only 25 reported cases. But we can see here that the pain duration was longer in the unfavorable outcome group. Also, the neurological deficit, the duration of the neurological deficit following pain was longer in the unfavorable group. And also, they had ventral hematomas. And another group had complete deficit. Here we can see a summary of the management of this patient group. If the gestational age was more than 34 weeks, we can perform cesarean delivery followed by spinal decompression on the same setting. If the gestational age is less than 34 weeks, then the patient can have cesarean delivery followed by spinal decompression only if symptomatic. In 2 case reports, the patients improved immediately after cesarean section, which doesn't require spinal decompression. Maybe it's because of the reduced pressure in the abdominal cavity, and their symptoms improved afterwards. Another group of patients who have the neurological deficit, then they can undergo spinal decompression and then delivery at term, whether vaginal delivery or cesarean delivery. Tumors was reported in 12 studies, including 32 patients. The most common tumor was hemangioblastoma, which becomes symptomatic during pregnancy in 43% of patients. These followed by giant cell tumors or schwannomas. 8 patients had antenatal resection. 13 had resection after delivery, and the reported fetal outcome was healthy. And 5 had termination of pregnancy and then proceeded to treatment or surgery. The outcome of patients and for the mother and the fetus in the tumor group was mainly dependent on the type of the tumor, whether it's benign or malignant, followed by their time of presentation and their neurological symptoms and the time of surgical decompression. The other pathology is traumas. We find it in 8 patients. Motor vehicle accident was the main cause, followed by gunshot wounds and fall from a ladder. The mean age of the patients was 25.6, and the mean gestational age was 26.9. 5 patients had antenatal spine fixation and 3 treated conservatively. And 2 patients had emergency cesarean section after spinal fixation. 1 patient had placental abruption, but the surgeons preferred to do ACDF first to maintain cord perfusion. Infections was reported in 9 studies with patients with spinal tuberculosis. Their mean age was 26.3, and the mean gestational age was 30 weeks. Anti-tubercular medications were initiated immediately and continued for 9 months to 1 year as per the WHO recommendations. Most of the patients were in their 3rd trimester, so they had delivery, which was followed by spinal decompression surgery with or without fusion. The outcome was excellent in the patients. 81% had a full functional capacity, and excellent neonatal outcome was reported in 72% of the cases. So we will discuss surgical considerations after all of these pathologies. First of all, when the patient is going for antenatal spine surgery and she is in her 1st trimester, usually positioning is normal. We treat her like any other non-pregnant patient in the 1st trimester. No literature suggested any other recommendation regarding patient positioning. We have a higher risk of pharmacological and radiological risks in the 1st trimester. And according to the American Society of Obstetrics and Gynecology, we require fetal and Doppler ultrasound prior and after procedures in the 1st trimester. For patients in their 2nd trimester, positioning, we can consider alternative positioning due to the size of the womb and the pressure, the aortocaval compression, because it leads to systematic and fetal compression. And fetal Doppler is required prior and after surgical procedures. If the patient is in her 3rd trimester, then we must implement fetal monitoring, as fetal distress is a high possibility and it could require an urgent surgery, and including preterm delivery. Anesthetic modality, most of the reported cases in all pathologies, they had their antenatal spine surgery under general anesthesia. There are a few that had their surgery under regional or spinal anesthesia. So we should consider regional anesthesia if possible, especially it has the advantage of less drug exposure and also less variable heart rate of the patient. We have always to remember that maternal safety comes first. We have to avoid hypoxia, we have to avoid hypocarbia, and also hypotension. Regarding positioning, prompt position is recommended in the 1st and early 2nd trimesters. It has been done in the 3rd trimester, but we require the spinal table and adequate lateral padding and enough room for the womb. And we have always to remember the physiological concern, because prolonged prompt positioning can cause changes to the mother and the fetus hemodynamics, and it might lead to preterm delivery. Limitations of prompt position. First, fetal monitoring is difficult during prone position, and we will not be able to perform emergency delivery and flip the patient immediately if there is reported fetal distress. Lateral position was also reported. Left lateral decubitus position was reported to avoid aortocaval compression. But right side positioning was also reported in some studies. It decreased the surgeon comfort and access of the surgical field, but it has the advantage of allow fetal monitoring and emergency access if required. Supine positioning is considered on the right hip, and lid apron can be applied to mother easily. We have also 3/4 prone, which has the same advantage as the lateral, and it increased the surgical access for the surgeon, and also it increased the surgeon comfort. We have sitting position, which is considered mainly for cervical and high thoracic access. It's not reported in most of the cases that we find, but it's reported in the literature in other review studies. It has the advantage of clean surgical field and reasonable surgeon comfort, and also complex setup, and it has a high risk. And it has the advantage of anterior access if fetal monitoring is showing distress and the patient required emergency cesarean section. So in conclusion, our analysis shows that with proper evaluation, proper anesthesia, surgical techniques, we can have a favorable surgical outcome for both the mother and the fetus in cases of spinal emergencies that occur during pregnancy. And also, functional recovery after these surgeries depend on many factors, including the interval between the presentation and the surgical decompression, including the type of pathologies as in tumor cases, and also the degree of neurological impairment prior patient presentation. These findings highlight the importance of timely and individualized management of spinal emergency during pregnancy, especially that some pathologies might mimic some common pregnancy complaints like back pain. And the mother safety is always come first. Thank you for listening. And if there is any questions. I don't find any questions in the chat box. Thank you so much for joining. We will announce the presentation for next week, and this session will be recorded and posted on YouTube by tomorrow. Thank you so much.